Welcome, everyone, and good morning. My name is Jill LaCapria, and I manage the medical education initiatives at ReCore Medical. Thank you for joining the first program in our series, Perspectives on Building an Interventional Hypertension Management Program. During each program, you will listen to experts share their unique perspectives on building a hypertension management program and why they have considered the Paradise Ultrasound Renal Denervation system as an integral part of their continuum of patient care. On our program today, we join two hypertension specialists as they discuss their unique journeys building a hypertension management program and what brought them there. You will also learn how the clinical efficacy and safety data of the RADIANCE Clinical Trial Program influence their decision to consider ultrasound renal denervation as a treatment option for their patients with uncontrolled hypertension. Please note that this presentation is sponsored by ReCore Medical. It is intended to discuss topics of hypertension and renal denervation that are consistent with FDA-approved labeling for ReCore's Paradise Ultrasound Renal Denervation system. CME credit is not provided. I'm excited to be joined this morning by our two amazing faculty, Dr. Tiffany Randolph and Dr. Michael Bloch, who have each been involved with managing patients with hypertension and building their own hypertension programs. I'm grateful they have agreed to share their experience with us this morning. Dr. Randolph is the director at the Advanced Hypertension Clinic at Cone Health Heart Care in Greensboro, North Carolina, and Dr. Bloch is an associate professor and the medical director at renowned Heart and Vascular Institute in Reno, Nevada. These are their disclosures. Our agenda this morning walks us through the state of hypertension management today and a few discussions on where hypertension management is going, including the option to add new FDA-approved technology. It'll talk about who is a potential candidate for renal denervation and also what's involved with building a hypertension management program. There will be time to address questions at the end of the program, but feel free to ask questions through the Q&A chat box on your console at any time throughout the program. We will make every effort to address your questions during today's sessions. And without further delay, I'd like to hand the session over to Dr. Bloch and Dr. Randolph.
Thank you very much, Jill. I really appreciate that. So I'm going to go through the first part of this presentation relatively quickly because we want to spend a lot of time about what we really think is the meat and potatoes of this presentation, which is building a center. But we're going to talk a little bit about the state of hypertension management currently and a little bit about the data that we've accumulated with the ReCore device. So I think it will come as no surprise to anyone on this call that uncontrolled high blood pressure is a major risk factor for death in the world. In fact, it is the #1 leading risk factor for death in the world, higher than tobacco use or obesity. And much of that excess death that happens because of hypertension is due to the fact that we do such a poor job of controlling high blood pressure. If you see on the right side of this slide, as I'm once again sure everybody on this call is aware, we have declining rates of hypertension control here in the US, where we're now controlling less than 50% of all patients who have hypertension in this country. And I think it's worth drilling down on that uncontrolled patient population to understand who they are. So once again, on the left of this slide, we see that about 54% of patients in the US are not controlled. When we look at that uncontrolled group and we make the determination as to whether or not they're aware of their hypertension and they're treated, what we find is that about 45% of those patients know they have hypertension and are being treated for hypertension. They're just not being treated aggressively enough. And that's really the group that I want to focus on today, the treated but not controlled hypertensive, which is really a failure of the delivery system. Those patients have been identified, they have been treated. We just need to be doing a much better job of getting them to goal. And let's make no mistake about it, every reduction in blood pressure that we see in these treated but not controlled patients translates to reductions in cardiovascular events. This is data from 2 different observational studies, both of which use pharmacologic treatment of hypertension that shows that even a 5 or 10 millimeter reduction in blood pressure, even if one doesn't reach goal, is responsible for a significant reduction in cardiovascular events, When we go down 5 millimeters across the population, we see about a 10% reduction in cardiovascular events. When we go down 10 millimeters, we see about a 20 millimeter reduction in those events. And the effect on stroke is even more pronounced. A 5 millimeter reduction leads to a 13% reduction in stroke, 10 millimeters to a 27% reduction in stroke. So I really make this clear when I talk to patients. The reason I want your blood pressure lower is I want to prevent stroke. I want to prevent future cardiovascular events. So we certainly have great armamentarium of medications and lifestyle changes that are available to us, and yet patients are still not controlled despite these medications. Part of that, I think, is we're not using our medicines as well as we could. Tiffany, I want to invite you on to talk a little bit about the algorithm that you've developed at your center, and we could talk about some of the strengths and weaknesses of it.
Yeah, absolutely. So one of the things that we decided to do when we developed our advanced hypertension clinic was to sort of standardize the use of medications to the extent possible, to find medications that were most efficacious, most affordable, and that utilize combination therapies wherever possible, because we know that all of those things help to improve the likelihood of patients being controlled on pharmacologic therapy. And so our center developed this algorithm where you can see at the top, the first question that we ask is whether or not they're African American, and knowing that for that patient population, they really should be started on a calcium channel blocker such as amlodipine or a thiazide diuretic, or the combination of the two if their blood pressures are more than 20 millimeters of mercury above goal in the systolic or 10 in diastolic. If not, then patients are typically started on, we chose valsartan. There's certainly some debates about ACE inhibitors versus ARBs, but given the fact that ARBs are more likely to be tolerated and that they're now much more affordable, we chose a longer acting, more efficacious ARB. But to be honest, your center could choose whatever they wanted. And then, it progresses through the algorithm with some recommendations about where we should stop and think about if people are on 3 medications or more, they should be referred for secondary assessment of causes. They should also be considered to be referred to our advanced hypertension clinic if our primary care colleagues or the cardiologist or anyone in the system is struggling to manage them. We also made note on the second side that after they're on 3 agents, the next medicine that we typically tend to reach for is spironolactone, and that also is guideline-based and been shown to be highly effective for patients who are able to tolerate it. And then you can see there's more and more prompts to send these patients to our center for management. If we're, at the 4th medication, thinking about adding things now like hydralazine and doxazocin, really would like for them to be seen at a center where they can be evaluated for additional therapies.
So having go ahead.
Oh, sorry. I was just wondering what your, if you kind of use a similar algorithm or what your experience is like from a medication standpoint.
We do. First of all, I think this algorithmic approach makes a lot of sense, and especially how carefully you guys have laid it out. We try to use one that's similar and guideline-based, just like this. I'm just always struck by how quickly our patients fall out of these algorithms, right? We spend a lot of time putting them together. We've tried to push ours out to all of our primary care providers. And for one reason or another, patients tend to fall out. And I think this is one of the reasons that we need another pillar of management, not just lifestyle and pharmacologic therapy, but interventional therapy as well.
Absolutely.
So we already have spoken a little bit to this. This slide just thinks a little bit about why we have so many patients that are treated and not controlled. And a lot of this really comes down to access, but also to adherence. Something we've learned more and more in the hypertension field is that we can prescribe more medications, but unless patients take those medicines on a consistent basis, they're not going to be effective. And many times they don't take those medicines for one reason or other, either tolerability or other issues. We also have the issue of provider inertia, where we see in multiple studies patients coming in to see their provider and not being up titrated on their medications. So one of the reasons that I've become interested, and I know Tiffany is as well, in renal denervation as another pillar in the management of these patients is that it is a one-time procedure that doesn't rely on physician inertia or lack thereof. It doesn't rely on patient adherence in order to have a durable effect on reducing blood pressure. So I really think, I know that don't want to speak for Tiffany, but I think she agrees that hypertension management is really moving past these traditional medication and lifestyle modification. We are always going to have that as a baseline. We are always going to be recommending lifestyle modification. We're always going to be recommending at least a trial of a baseline of well-tolerated fixed dose combination antihypertensive medications. But I think we see that there is a need for a third pillar of therapy, an interventional therapy. And RECOR has developed the RADIANCE Ultrasound Hypertension System to be a part of that third pillar of therapy. I've been very lucky to be involved in this clinical trial program. I've been on the steering committee. And as you can see, it's been a very long journey. In some ways, we're just at the starting line now with FDA approval in late 2023. But this is the result of a number of studies done by a number of different investigators, and importantly, a number of different subjects and patients that have been involved in these clinical trials. So just a bit about the procedure. So this is an ultrasound-based renal denervation device. It's an intravascular device where we place an ultrasound probe into the renal artery, and then we sonicate at 2 to 3 sections of the renal artery, knowing that the renal nerves travel along that renal artery. So it uses ultrasound, which provides a lot of energy across the blood vessel wall. So we only need a 7-second sonication at each of those points, but it does provide 360-degree circumferential energy at a depth of about up to 6 millimeters. Importantly, though, ultrasound is pretty hot, so it does ablate those nerves very effectively, but we don't want to damage the endothelial wall. So there is a hydrocooling balloon where water is circulating throughout the balloon, throughout the procedure, that cools the endothelium so that it is not damaged during those 7-second sonications. So you see that a little bit better here on this slide, 360-degree energy through the sonication, but there is a cone of cooling in the center of these rings where that cooling balloon is. So we're getting out to a depth of about 1 to 6 millimeters with that initial cooling balloon keeping the endothelium cool. And we know that that depth is important, and we know that sonicating at multiple areas across the length of the renal artery is important, because the nerves that follow the renal artery do not follow a uniform course. They sort of dive and come back up to the surface of the renal artery as they go along the course. And so we really do need to be making sure we're getting deep enough to get those nerves, but also that we're sonicating in a 360-degree fashion so we can get as many of the nerves as possible. And it does look like if you do 3, and this is from some early data, if you do 3 sonications across the length of the renal artery using this device, you will denervate approximately 80% of the sympathetic renal nerves, both the afferent and the efferent nerves. So the idea was that this therapy could be used to lower blood pressure, and we've studied that in 3 landmark clinical trials that really made the bulk of the submission that we had to the FDA and to regulatory bodies in Europe. These are 3 separate studies: SOLO, RADIANCE 2, and TRIO. So SOLO and RADIANCE 2 were proof of concept studies where patients with uncontrolled hypertension and a GFR of greater than 40 were taking off all of their medications at baseline. So they're taking off medicines, and then assuming their out-of-office blood pressures were still elevated and they had appropriate renal anatomy, they were randomized to either receive renal denervation or sham. TRIO on the right side of this slide is a very interesting study. It's really in this space, the only study in the renal denervation space, the only study in patients who truly have resistant hypertension. So these were patients who were on 3 or more medications, who were all taken off whatever they were taking at the time and put on a fixed dose 3-drug combination pill with an ARB calcium channel blocker and thiazide type diuretic. And then they were stabilized on that dose. If their out-of-office blood pressure was still elevated, their imaging was appropriate. Once again, they were randomized to either ultrasound or to sham. The initial primary endpoint of these studies was daytime ambulatory systolic blood pressure change between ultrasound and sham at 2 months. But importantly, after 2 months, these patients remained in the study. Medications were up titrated. So we do have a lot of data about durability from these studies and a lot of data about what happens when we add back background medications to a patient who has been denervated. Importantly as well, these patients who were originally randomized to sham were eventually offered a crossover treatment that many of these patients took advantage of. So here you see the main results of the clinical trial. This is the primary endpoint, change in ambulatory blood pressure as compared to sham. This is daytime ambulatory at 2 months. And so you can see in the two studies where patients were taken off medication, significant reductions in blood pressure, about 6 or 7 millimeters as compared to sham. And in TRIO, the trial with resistant hypertension, about 5 millimeters as compared to sham, 8 millimeters as compared to their baseline values. This is looking at some of the secondary endpoints at 2 months. Once again, daytime ambulatory already presented to you. That was the primary endpoint, 8.5 millimeter reduction as compared to baseline. Nighttime ambulatory also significantly reduced, very important for our patients, as we know that nighttime ambulatory blood pressure is one of the strongest predictors of cardiovascular events. And then more clinically relevant, perhaps, is home systolic and office systolic blood pressure, shown on the right of the slide. So home systolic on average dropped by 8.4 millimeters as compared to baseline. Office systolic, 10 millimeters as compared to baseline. As I mentioned, we do have some durability data out of these studies. Patients had medications added back. And once again, you see that in the setting of this background medicine, we continue to see significant reductions out to 3 years, and we've gone even farther out with some of these patients. Finally, safety, incredibly important. It does appear that this is very safe. This is a pooled analysis of all 3 studies, and as you can see, very low rates of adverse events and a very well-tolerated procedure. There is a little bit of pain. We do need to provide analgesia or anesthesia at the time of the procedure, but that can be easily controlled in the cath lab. So that data, as I said earlier, was presented to the FDA, and in November of 2023, RECOR received notification that this had been approved for use in the US. And as you see here on this slide, the indications for use in the United States is very broad. Paradise Ultrasound Renal Denervation System is indicated to reduce blood pressure as an adjunctive treatment in hypertension patients in whom lifestyle modification and antihypertensive medications do not adequately control blood pressure. So once again, focused in on that treated but not controlled patient population. That's who we should be thinking about for renal denervation. But obviously, that's a very broad group of individuals, as I started my comments with. That's tens of millions of people in this country are treated but not controlled. So we do need to think a little bit about how we're going to further hone down this patient population to decide who may be a good candidate for renal denervation. I should mention there are, of course, contraindications and warnings and precautions as well for this device, just like we would with any therapy. There are some issues around the renal artery itself, making sure you have an appropriate, healthy renal artery before you're going to do this procedure in them. That includes the size of the kidney artery and the fact that it's, and the presence of significant renal artery stenosis is a contraindication. It's also only currently indicated in adults, contraindicated in patients less than 18 years of age, and those who are pregnant, those who have a known allergy to contrast medium. Also, so you see some warnings on the right side of this slide that really require good training before we go ahead and use the device, particularly making sure that we're picking the appropriate balloon size and using the balloon appropriately with the cooling balloon. And as you see the warning, not to use saline in that cooling balloon, but rather to use sterile water, and never advance to withdraw the catheter if you feel resistance. And avoid multiple balloon inflations. So these are contraindications, warnings, and precautions that, if you do get trained on this device, will be a very important part of that training. So as I mentioned, we do need to think a little bit more carefully about who might be a candidate for renal denervation. And there's been a number of societies who have presented scientific statements or guidelines on this very question. So I think I always like to point to this document, which is, I think, the most comprehensive document that we have out there, which is the 2023 ESC Clinical Consensus Statement on Renal Denervation. And this obviously for Europe suggests that renal denervation may be used in patients who have uncontrolled resistant hypertension, that is office greater than 140/90, confirmed by out of office greater than 135 in the daytime, who are treated with 3 medications and have a GFR that's greater than 40. But it may also be a treatment option in other patients who are treated but not controlled, who express a preference to undergo renal denervation as opposed to increase their medications. And we're going to talk quite a bit about that in the next few slides. Other considerations are very important as well. This consensus document, like others around the world, really suggests that we look at a patient's global cardiovascular risk, including target organ damage and established cardiovascular disease. So we are using this technology really in patients who are going to get the greatest benefit, not just in terms of their blood pressure reduction, but in terms of their potential event reduction, given their high cardiovascular risk. And this is very similar to statements that have been presented in the United States, including this SKY. This is from SKY. They put out 2 different statements. This is from their August 2023 statement that really, I think, mimics very much the ESC recommendations because they're looking at the same data. So once again, in terms of patient selection criteria, we have patients with resistant hypertension would be a good potential target for this technology, but also those with uncontrolled hypertension despite lifestyle modification and medications, who are either intolerant or don't wish to increase medications. So this as an option to up-titrating medications. Once again, thinking about patients at higher cardiovascular risk, so we are getting that greater absolute benefit. This document, though, importantly, and this is, I think, what we're going to spend the bulk of the rest of this morning talking about, is it talks a lot about what we need as institutions to be providing this therapy. Because the idea behind this therapy is not simply that it's a one-time procedure and then these patients go off and never need any follow-up. Really, we think that this is going to get the greatest benefit where this is therapy is embedded in a care algorithm that includes not just this therapy, but lifestyle modification, medications, and long-term follow-up of these patients to make sure that they are adherent with their background medication, and that we're continuing to follow these patients up. So just kind of summing up who may be a potential candidate for renal denervation, as I mentioned earlier, patient preference is a big, important part of this that I'm going to get to in just a moment. But the real clinical question that happens in the office is when you have a patient who's treated but not controlled, once again, focusing on that patient population, we have data and guidelines that support using this therapy in almost every patient who is treated but not controlled in the right setting. So the key question when you're talking to a patient is, what is the relative risk and benefit of adding another antihypertensive medication versus renal denervation? First thing to recognize is that doing nothing in a patient who's treated but not controlled is not appropriate. So I have this conversation frequently in my office. How can we balance pharmacologic therapy versus interventional therapy? We know the efficacy is roughly equivalent, renal denervation versus adding a medicine or 2. Tolerability may actually favor renal denervation. Safety, they both appear to be very safe. If a patient struggles with adherence, renal denervation is probably a good option. Durability is a little bit unclear, although I think that the data with renal denervation in terms of durability continues to grow and become more robust. And the durability of medications, I think, is often under question because medicines are only going to work if patients continue to take them. If a patient is very sensitive to cost will likely favor increase in medication, but it really comes down a lot to patient preference. What does that patient want to do? I can continue. I've spent my entire career taking these treated, not controlled patients and writing them for more medication, but it's only going to work if a patient wants to take more medication. If the patient prefers renal denervation, I think this is an option that we're going to need to offer our patients.
Thank you, Dr. Bloch, for your wonderful presentation and sharing all of the data with the audience. I just wanted to take a moment here to poll the audience and ask a question, and feel free to, choose A, B, or C. But for your patients with uncontrolled hypertension who do meet the criteria for renal denervation, what percentage of them do you feel would prefer an intervention over adding an antihypertensive medication? 5 to 10% of your patients who meet the criteria would prefer it to another pill. More than half of your patients who meet the criteria would prefer a procedure over another pill. Or C, I don't think many of my patients would want a procedure. And I'm going to kind of leave this here for a minute and also pose the question to Dr. Randolph and Dr. Bloch. What percentage of your patients who meet criteria prefer it? And Dr. Randolph, I'll start with you while we wait for people to answer the question.
Yeah, great question, Jill. It's not been that long that we've been able to offer this option commercially, but it's been actually really surprising to me how frequently patients are open to having a procedural approach. By the time patients see me in advanced hypertension clinic, they've already failed a lot of things to get to me. They've probably seen their primary care provider. Many of them have seen another cardiologist, and they're coming to me as another source of hope. And, we've probably gone through several medication titrations as well. So many, I've only had, we've commercially done about 9 patients so far. I've probably introduced it to 20 to 30 patients. Many of them have said yes, some of whom we're still working on authorizations through insurance, but it's also been kind of surprising. It's not, you may think it would just be like younger people, but some older, I haven't really found that just because someone is older, they wouldn't want to do a procedure, or I haven't seen, obviously small numbers so far, but many patients have been very, very open to it.
Great.
Yeah, I would agree. My experience has been more in the clinical trial realm than in the commercial realm. And we originally, as part of our recruitment for the clinical trials, recruited on social media, which I at the time thought was crazy. Who is going to answer a social media ad to have a catheter put in their renal artery and those nerves blasted with ultrasound? And we were shocked by the amount of calls we got. And it really taught me something about the management of hypertension, management of my patients. I'd always assumed, based on the non-adherence rates in our office and in others, that patients didn't really care about their high blood pressure. And what I've been taught by this process is that patients do care about their blood pressure. They just, there's a large segment of them that just don't want to take more pills. And having something else to offer them is really been really exciting for us. Because there are a group of patients who, when they hear about it, it's like, there's no way I'm going to do that. I'll be happy to take more medication. But there's at least a third of patients who are pretty adamant that they don't want to take more medicine and would be willing to look at a technology like this.
Great, thank you. Now let's look to see what the audience member said. And it looks like the majority said that more than half of their patients would prefer procedure to another pill. And I think you guys are going to talk in the next slides about some of the patient preference studies that have been done over the last couple of years. So that's great. I think we're right on target again.
There have been a number of patient preference studies that have been done that have shown that patients, certainly are at least open to a discussion of this technology. These have been done different parts of the world, and you usually see somewhere in the 30s or 40s percentage wise of patients. So about a third to a half of patients, very similar to I think what our audience said, are willing to consider renal denervation. Once again, a higher number than I would have thought. Obviously, the folks on this talk are wiser than me, but a lot higher percentage than I would have thought are interested in learning more and potentially proceeding with an intervention as opposed to more medication. When you sort of drill down on that, this is from one particular study, what you see is that patients, in general, the number of medications that they're on does not affect their acceptance of renal denervation. But if you look at the extremes, and I found this, I don't know if Tiffany has as well, in my patient population, it's patients who are on no meds because they don't like taking meds, they don't tolerate meds, they won't take meds, who are the most likely to like this technology. And then patients who are on 5 or more medications, which they may or may not be taking, but these are patients who have been at least prescribed 5 or more medications, are those who are more likely to accept it. I think it's also interesting to note that their blood pressure doesn't really affect their willingness to accept renal denervation. And we think it should. And this, I think, is important that we recognize that we want to have the patient voice in this conversation, but the patient also needs to be educated, right? You should be more enthusiastic the higher your blood pressure is. Patients who are in the 120s probably shouldn't be considering renal denervation. So I think it is important that we're hearing both voices, the provider voice or providers, more than one provider, and the patient voice as well. And that's a really important part of the recommendations that have come out from Sky and from others, that this should be a process. It's not just referring patients for a study and a intervention. It's a process whereby we're making sure we're moving through this in a stepwise fashion. Patients get referred into a system. They're evaluated by somebody who at least has an interest in hypertension. They're educated about the importance of hypertension. We try to rationalize their background medication, rule out secondary cause of hypertension, make sure that we do appropriate imaging so we know that they're a good candidate. Then we'll talk to them again about the procedure, consent them, do the procedure, and then make sure we have appropriate follow-up that's scheduled. So really embedding this in a systems approach is, I think, paramount if we want to see good results with this technology. So we're going to shift gears here a little bit to talk about building a hypertension program, and I'm going to turn over a lot of this to Tiffany, but we do have one polling question before we move on.
Before we go there, Dr. Bloch, while we were talking about patients who would qualify for renal denervation, there was a question that came in from the audience. I just want to throw it out to you guys. The question reads, I have a patient well controlled on 6 antihypertensive medications. Would you offer this person renal denervation? And if so, how many drugs could you expect to take off after the procedure? So maybe Dr. Randolph, maybe you can address that. This patient is controlled, but obviously 6 medications is a lot. So what are your thoughts on that?
I think this goes a lot back to what Dr. Bloch was just mentioning. Sometimes it's the patients who are controlled on the most medications who have a lot of symptoms. So actually I have a patient who I referred for a renal denervation who was similar to this. He was actually on 7 medicines, but he was a very young man, and some of them included clonidine and beta blockers and things that are certainly not first-line medications. And for that particular patient, he actually still wasn't controlled. But I think, you know, you could extrapolate even to what this person is asking. If someone is controlled but having symptoms from their medicines, and you have a conversation with them and they're interested in alternatives, I think that this is someone who you would consider it. You know, if they're completely asymptomatic, going about their business and, you know, taking their medications as prescribed, then, you know, it's probably not the first person that I would reach for. But I think it just kind of goes back to what Dr. Bloch was just mentioning of us sort of trying to not be biased about who might be interested in a procedure such as this. And I would consider it.
Great. Thank you so much.
Sorry about that.
It's okay. So let's move on to the next.
I would say I agree very much with Tiffany. I just, the one comment I would make is that is a bit of an off-label usage of this technology, right? The technology has been studied based in people who are treated and not controlled. It's approved in patients who are treated and not controlled. So I think I've been very careful about trying to use this technology in the way that it's been studied. So I agree very much with Tiffany. If a patient's having specific problems with their medicines and I need to stop those medicines, well, that's one thing, right? I'm going to stop their medicines, then they're going to become uncontrolled, and then I think they're a good candidate for this technology. But if a patient is taking 5 or 6 medications and they're tolerating it quite well, I think that sticking with medical therapy makes a lot of sense.
Great. Thank you. All right. So we have one more poll question here. So I'm going to read it through. And this next part of our conversation, we're going to talk about building a hypertension management program. And these two physicians on our panel here have both done this, and they're going to share their wisdom with everyone in the audience. So who in the audience has already built one? And the different options, I haven't started one yet, but I'm considering it. I'm in the early stages of building one. I've built a program already, but I'm trying to expand my reach. And then the last one, I have no interest in building a program at this time. So I'll give a couple minutes. The next couple of slides, we're going to talk mostly to Dr. Randolph about her experience in building her own hypertension clinic and hypertension management program. Obviously, when she did this, there wasn't this other option on the table. There were no approved devices on the market to treat patients with uncontrolled blood pressure. But we'll kind of let her walk through what her experience was, how she built it, why she built it. And I think it'll be really interesting to kind of learn from someone who's already gone through it, what some of the, maybe some of the challenges, some of the opportunities that she had along the way. And then Dr. Bloch also has been running his own clinic as well. So he can throw in some pearls to kind of help anyone who's thinking about it and building their own program. You know, hopefully you get something out of that. So let me, I'm going to see what the results are here. So majority of you are in the early stages of building one, and then we have some who haven't started but considering, and then a couple who are building but they want to expand. So how about in the next few slides, you know, we can kind of touch on, you know, what does this look like?
Absolutely. So as you mentioned, when I started our clinic back in late 2019, early 2020, renal denervation was not commercially available. And so I just had a particular passion for the management of hypertension. And some of that grew from my training back in fellowship, but also as I joined my first job out of training, I realized that, like most of America, our institution was not controlling hypertension adequately. As Dr. Bloch already mentioned, you know, almost half of the adult population has hypertension, and we do a terrible job of controlling it, despite the fact that it's the greatest predictor of cardiovascular death and death overall. And so the first thing I did was taking an assessment of what exactly was the rate of hypertension control in our system. And we were around 60-ish% control, which is actually, unfortunately, even better than national, but still a failing grade, at least in my book. But having that data really helped arm me with an impetus as I spoke to our leadership and as I spoke to our service line about the reason why this was so important to do, not just in general, but in our institution. The other thing that I did was take a look at our current system as far as the way that hypertension was being managed from a primary care standpoint, nephrology, cardiology, and so forth. And what I found was that there was a lot of variability in management, even within our own cardiology group, and that there just wasn't a lot of clarity as to who was ultimately responsible for this disease process. And so ultimately it ended up being nobody really was taking ownership for it. I also noted that although we were starting to take some systematic assessments of social determinants of health, we all know that these are one of the main reasons why hypertension can be uncontrolled, right? If you're dealing with an aging parent in the home and working all day long, or if you don't have access to healthy foods and there's nothing, you're living in the middle of a food desert, these are all things that make it incredibly challenging to control hypertension. But as a health system, sometimes we don't do the greatest job of assessing that. And even when we do assess it, we are not necessarily documenting it in a systematic way or making any systematic interventions on these things. I also found myself frustrated that, you know, in my 15, 20-minute visit with patients, I say, you know, eat right and exercise, but what does that really mean? We don't necessarily have we didn't have a lot of programs to refer patients to. Availability of nutritionists and things like that has been somewhat limited. And so we wanted to create a more comprehensive option for patients to help better manage their hypertension. The other thing I noticed was that when people's blood pressure was not controlled, there wasn't a point person within the health system. There was nobody who necessarily stood out as someone who wanted to see these patients or had any additional expertise in it outside of their general training or fellowship training. And so I wanted to be that person. The thing that I found is that in building our hypertension center, it's actually become a great opportunity for clinical research for our patient populations, both things that I've led as a site investigator as well as other larger trials. And the timing actually worked out very nicely for the FDA approval of renal denervation, because we already had a lot of the needed infrastructure for being able to have patients who are ready to be considered for this therapy, and also who've already had the appropriate evaluation prior to referring them for RDN. So I kind of mentioned a little bit about, these were just my key steps. You know, hypertension centers are very different. If you look across the country, what people call hypertension center may not be the same. The sort of gold standard would be centers who've gone through the certification process through AHA as a center of excellence. And I encourage anybody on here to look on the website there to see exactly what all that entails. One of the things that I personally did was take the board exam and become a certified hypertension specialist. And as a cardiologist, I kind of had a lot of bravado in thinking I already know everything about hypertension management. Why do I have to take this extra exam? But I actually learned a lot from doing that exam, and I would encourage people to think about doing that as well. But as far as creating stakeholder alignment, the first thing I had to do was figure out, in a community-based practice, who's going to provide me the time to be able to come out of my general cardiology role in clinic and be able to see patients specifically for this interest. And what I did was we have an accountable care organization within our health system. And so it seemed like a very obvious alignment of goals to have an organization whose goal is to help with the upstream preventative issues and help prevent hospitalizations, of course, for strokes and hypertension and heart failure and all the things that Dr. Bloch so nicely showed us, that even just a 5 to 10 millimeter of improvement in blood pressure control helps to prevent. And they did allow me one day a week to sort of step out of my general cardiology role and to become the hypertension center. Because at first it was a little bit slow. You know, I did not have full patients as we were building up the patient panel and so forth. The nice thing about having renal denervation available now is that it creates alignment even within cardiology centers, especially, to have someone who is interested in being the hypertension expert within the group, because of course, there are a lot of ways that renal denervation can be rolled out, but sometimes, at least maybe it's just my center, but a lot of our interventionalists may not necessarily want to take the ownership of doing a secondary assessment of causes or taking care of the patients if their blood pressure remains uncontrolled after they've had renal denervation. But it still serves as a nice pipeline and has helped to bring patients into our heart and vascular center who otherwise may not have been able to see us. Other things that key stakeholders are thinking about: who would be your referrers? So, of course, primary care doctors, and as we all are moving towards value-based pay systems, a lot of those metrics, they're not going to care who got the blood pressure controlled. If cardiologists got blood pressure controlled, primary care is still going to get credit for those things. And so, you know, we had to talk with them and make sure that they knew the proper ways to refer to us, help them to understand what we might have to offer in addition to the things that they were already doing, and also make sure that they understood that we were not in any way trying to take ownership of their patients and not plan to send them back. Other stakeholders, you know, every health system looks a little bit different. For some places, nephrology might be primarily taking care of patients with resistant hypertension. So I think it's very important to have nephrologists on board as well. And then as you go through you'll find that as you're going through your secondary assessment of secondary causes, there you will want an endocrinologist on hand as you inevitably find hyperaldosteronism or other, Cushing's syndromes, things that people who are not trained in that subspecialty may not be as well equipped to help manage when they're found. The next thing that I decided to do was just sit down with the guidelines, sit down with the hypertension guidelines and try and figure out what I wanted every patient who came through the clinic to experience. And a lot of that came back to helping them with lifestyle. So I mentioned social determinants of health. We have a social worker embedded within our clinic. We have we call it a care guide, but it's really a health coach who helps to follow up with smoking cessation and helping patients with stress management, things like that. For every single patient who comes to the clinic on 3 or more medicines, our nursing team calls the pharmacy, because you will be surprised how often, patients have not filled a prescription since 2021 and it's still staying on their med list. And you can find some surprising things that open up discussions for the patients as far as reasons why and so forth. We have a partnership with the YMCA, with the local YMCA, and have created a program for exercise and nutrition. And I'll show you a little bit more about our secondary cause assessment. You already saw our medication algorithm. And one thing I really would stress is to try and automate whatever you can possible. So this is one of the things that we've done to automate this. And we've taught our CMA who rooms patients to go through the social determinants of health. And she clicks through them with 1 or 2 questions of each of these things. It really doesn't slow her down. I'm able to then, as I pull up the patient, see, okay, I need to talk to this person about physical activity. That's an issue for this particular person. And now also those social determinants of health have been documented, as well as what we do to intervene on them. We do that as well. Another thing that we did was we worked with our IT team to embed secondary causes of hypertension screening. So at the beginning, this was me. It started up with me seeing patients initially, and then I had a pharmacist, a clinical pharmacist, who would help follow up with the patients. But it's grown, and now we have one nurse practitioner, and we're about to get a second one to help with the patient volume. But you can imagine, as you bring on more providers, it can be even more important to standardize these things and make sure that they're being followed and checked systematically. And so we have a listing here of all the secondary causes, what we've done to screen for them, and then that gets populated into the note as well. I think what you're probably seeing is that this is a team sport. And so this is just gives you a sense of all of the different healthcare team members who have been involved in our process. So this is just some data from our early days, where the top blue line shows you what patients' average initial blood pressures were on average. And then as you follow them through, what their blood pressure, most recent blood pressure in our system is recorded in the orange line. And so if you can see, if you look at like patients who've been in clinic for 4 visits or more, let's say, on average, their first blood pressure was 162. On average, their last blood pressure in the system was 142. A little bit better for the patients who've been in 5 visits or more. But what really draws my attention is, one, it's great that people's blood pressures are dropping on average 15 to 20 millimeters of mercury. That translates into great health outcomes improvements. But it really highlights the fact that on average, their blood pressures are still above goal, and they're still at risk. And these are patients who've been through all of the steps I just mentioned to you. And so it just really builds the case for the fact that despite all of our best efforts with all the things we mentioned, lifestyle, social determinants of health, many of these patients still need an additional option. It's nice to have a procedural option to offer as well. Michael, what would you say your experience has been like with patients when they're coming to your hypertension clinic?
Yeah, I would say, if you've, I liked your comments about each hypertension system or center is unique. And I think that's very true. When you've seen one, you've seen one. I think ours looks very much like yours in a lot of ways, but looks different in a lot of ways. And I think one of the most important things that we'll see in both of our stories is that we really had to do a needs assessment and what the institution needed. I was very interested when I came to the institution I'm at taking care of those resistant hypertensive patients or refractory hypertensive patients, sort of the worst of the worst. And it turned out that really what our system needed was a lot of help with those more mild to moderate patients with hypertension who were in primary care, didn't need to go to a center. So I use the term center a lot. I always mean to use the term system. So we actually have pharmacists that are embedded in our primary care pods where they can assist in up titration of therapy and lifestyle modification and other things. And then we have the more resistant patients come and see our team at the main hospital. So every center is going to look a little bit different, but I do think that this is really a great opportunity for those who are interested in building a center, for those who may just begun building a center. Having renal denervation available can get everybody's attention. But I think what you've, and it's, I think, an important part of building a center. And you see on this slide, some of the things that we found important when we wanted to add interventions to our center, right? We obviously wanted an interventionalist. We needed to identify a clinical navigator. We have a nurse who navigates folks through this system, a reimbursement specialist. Imaging and lab time was really, really important for us. Our cath labs are really busy, so making sure we have adequate lab time. These are elective cases that we can get these patients on. And then really talking a little bit about how to recruit has been important, and I'm going to share my thoughts about that in the upcoming slide. But I think what you saw from Tiffany's great presentation, the great results that we have, is we'll measure success in a center or a system not by how many patients we denervate, but by how well we're controlling blood pressure. And even without offering renal denervation, right, we see that these patients are much better controlled when we take a systems approach to managing their blood pressure. And that's what we've tried to do. And that's really my hope. The assumption is that in most of these systems around the country, the minority of people will be denervated, and the majority of them will have just up titration of their therapy. But I do think one of the things is, as each of you in the audience, is something we've thought about a lot. I don't know about how Tiffany thought about this, but as you're putting together your practice and you're going out to the community to talk about it, you really have to think about how big a funnel you want to have for patients coming in. There are, in every one of our communities, every one of our health systems, there are a huge number of treated but not controlled patients. We is somebody who has a full-fledged hypertension center with pharmacists and multiple providers and multiple sites. We want to cast as wide a funnel as we can. Send us all your treated but not controlled antihypertensives. We'll find where they fit in the system. We'll get better control. But I think if you're a little bit smaller or want to be a part, say, of a cardiology group where you're just going to see hypertension patients with a couple of providers, a couple of days, I think you want to be a little bit more careful in terms of how you go out and recruit, because you can be very much inundated. So perhaps, seeing the more resistant or refractory patients rather than all comers. And if you're an interventional cardiologist and you want to start giving this technology, you probably want to be even further down in this funnel where you're really seeing patients that have already been adequately worked up, medically managed, and don't have potentially have a lot of time to be seeing hypertensive patients in the office. And in that setting, I think you really want to think very carefully about who your partner is going to be in terms of the medical management of these patients and how you want to limit the referrals that are coming in to patients that are going to be more likely to need renal denervation. And I don't know if you had any further thoughts about that, Tiffany, or wanted to share any cases with us.
Yeah, I agree 100% with what you just said. In the very beginning, my biggest prefers were my cardiology colleagues. And so those patients a lot of them were very clinically challenging and much higher blood pressures to begin with. And then as we started to have more success, we started opening up and recruiting more primary care provider patients. And another area that's, I think, sometimes not thought about often is OBGYN, who is primary care for a lot of women and have a lot of times even less interest or experience with treating hypertension. And what we did find was that we started to be flooded with patients who probably didn't really need our level of care. I agree 100% that clinical pharmacists are underutilized, super valuable tools that we partner with and have great success with their ability to help titrate patients. Another thing that we've done is I've taken on sort of an education role, especially with our primary care providers, and shared our algorithms with them. And that and time have helped to have the patients who've come to us be more clinically appropriate. And I've seen that they've kind of gotten further down on our algorithm by the time that they reach us. And then the other thing that I've seen is that we've even seen them starting to do more secondary causes assessments, which is great and certainly sort of streamlines patients who are good candidates for RDN. I actually do have I saw a patient this week who I started seeing him back in maybe December of last year. And he was a 78-ish year old man who had resistant hypertension. He has non-obstructive coronary disease, diabetes, CKD2A, I believe. And his initial blood pressures in the office were around 150s over 80s. At home, he was averaging in the 140s over 50s to 60s. And when I first saw him, he was on several medicines. He was on amlodipine, chlorthalidone, lisinopril, and metoprolol. He also had a history of SVT. We had tried multiple medication changes on him, got him into swimming, really, really working on lifestyle modifications. He had all of the workups. Renal Dopplers were normal, thyroid, renin, aldosterone, all of those things were within normal limits. And ultimately, after seeing our pharmacist for several visits and myself, we referred him for renal denervation back in March. And I think he had his procedure in April. And the first visit, when he came back to see my interventionalist colleague, his blood pressures were still uncontrolled, hadn't seen much change. That was a little like maybe 3 weeks after the procedure. And then I just saw him this week, actually, which was about 2 months after the procedure. And his blood pressures at home were averaging 120. He's an engineer. We're averaging 128 over 74. He's very methodical about his averages. And in the office, his blood pressure was 138 over 84. So not that we expect those types of responses in all comers, looking at the data, but we certainly are seeing a trend towards improvement without adding any more medications. So he was quite pleased after being a little bit disappointed at that first visit that he didn't see an overnight drop. He was very, very pleased with the way things were going now, as was I. So.
That's a great case. Yeah, and I think that's a common theme that we've seen with renal denervation is that it does take a minute. And that perhaps the efficacy, this is somewhat controversial, but perhaps the efficacy, out at 3 to 6 months is more than you see, at a month or so. So what are your plans for, remember, by the way, I think that was just a great outline of the SKY and other documents for how to walk a patient, through the algorithm of treating their hypertension appropriately, and then if not controlled, referring for renal denervation, and then seeing them back and follow up. When are you going to see that patient back again? Blood work, imaging, what plans do you have?
So one thing that's interesting, actually, even backing up. So we had renal Dopplers for the patient beforehand. We did not do a CT beforehand, but I've had some conversations with my interventionalist, and we're kind of going back and forth and thinking that going forward, we might, as long as renal function permits, try to get a CTA just to help with planning from his standpoint. I don't have any plans for any repeat imaging for him per se, but we will be seeing him back in about 4 months just to make sure that things are stable, and understanding that if his blood pressures do start dropping, he'll give us a call to see him sooner, make any changes as needed. As of now, I did not take him off of any medications because his home blood pressures are right on target with where we want them to be. But he does have some intolerances to one of his medications. So he is very excited that hopefully we'll be able to pull that one medication off in follow-up.
Yeah, that is always the hope, right? I do think I try to set up, and I know you do the same, as we've talked about this offline, but patients often are doing it because they think they can end up taking less medicines. But I think this is a great example. I really try not to set up that expectation, right? This is a patient you now have under great control with 3 medicines and renal denervation. If he stops a couple of his medicines, his blood pressure is going to be right back to where they were before therapy, right? So the idea is, in general, and obviously there's exceptions, but taking patients who are not controlled on what they're on, leaving them on what they're on, and getting them further towards control. Although we all have anecdotes when we've been able to stop medications on some of these patients. Sure. I think your comments around imaging are very much what we've seen with others around the country as well. That preoperative CTA, I think most of our interventionalists find helpful, and just having the right size balloon on the table and kind of ready to go. And, I agree that given the low incidence of renal artery stenosis that we saw in the clinical trials, we did post-procedure imaging in everybody in the clinical trials and saw such a low rate of renal artery stenosis. I think most people are not re-imaging the kidney after doing clinical cases. So I think that's a really great case.
Yeah, we did repeat a basic metabolic panel, especially given his renal dysfunction. I think his baseline creatinine prior was around 1.5 and post it was 1.4. So certainly did not see any damage with the procedure.
Great. I think we have one more.
Yeah, I'm gonna interject right now because I see that we're up on time. I don't know if the program is just going to shut off, maybe not. But I did want to say we did have a couple of questions in the chat. I know there's one more slide. But kind of going along what you were just talking about with your patient, there was a question on, where would you start if you are going to take any medication out? And it sounds like if their blood pressure is better controlled, they're still tolerating the medications, you'd probably leave it as is. But if they were, much lower with their blood pressure and you could start to remove, are there specific medications that you would choose to take away? Would it depend on what they're tolerating, what they're not? Just real quick, and then I have another question, Dr. Randolph, which is probably more specific to you on discussions on, prior authorization, and does determinants of social determinants of health documents, does that help in prior authorization and gaining any type of approvals in your experience? And are there any other factors that you've seen where insurance providers, are requiring to get approval? I think those are some things on the audience's mind.
So I'll take the first easy question. I'll take the easy question. I'll leave you the much harder second question. So I think in general, as you already heard, the concept usually is not we're doing this in order to down titrate medicines, right? We're usually doing this as an alternative to up titrating medicines. So I try to set up the expectation that we are going to be stopping medicines. But if we are, it's sort of just moving back up the algorithm that Tiffany shared, right? Those moving the later added medicines that are usually less tolerated are the first ones we would get rid of if we could.
Yeah, I agree. And then the other thing I would just add to that too is just if we were fortunate enough to be able to take something off, just looking at what their other underlying comorbidities are. So, if they have heart failure with reduced ejection fraction, or if they've got atrial fibrillation, things like that, I'm probably not going to discontinue their beta blocker. Versus if they don't have those issues, that's probably one of the first things I would take off, just sort of looking at the overall picture. If they've got diabetes, especially, I would want to leave their ACE or ARB, things like that. And certainly anything that they have intolerances to. And then regarding the more challenging SDOH question and insurance prior authorization, I think one of the things that I do is just, and I don't know how much it translates, but when you look at what the guidelines say, as far as, patients who are good candidates for it, they're recommending attempts at lifestyle modifications. And many of the SDOH issues like exercise, physical activity, smoking, these alcohol, these are all sort of lifestyle things that can contribute to blood pressure. So I think that the more that you can document that the patients had these issues and that they've been addressed and that the blood pressures remain uncontrolled, I think the better off you are from a likelihood of a approval standpoint. The other thing that I think is very important is to document their average home blood pressures, whether that is and a gold standard, of course, is having 24-hour blood pressure monitoring. And that is incredibly valuable if you're able to get that. But if not, just having patients checking their blood pressures in a guideline-based way, sitting, resting 5 minutes, averaging their blood pressures multiple times over, in their home setting, and just documenting that the blood pressure truly is elevated at home as well as in the office, I think also helps with approval from insurance standpoint.
Great.
And just
can I just follow up? Yes. And can I follow up on that question as we're talking about billing and home blood pressure monitoring? Are there any codes specifically for telemedicine? Are there limits to how many telemedicine visits you can do with a patient or home blood pressure monitoring that you can do with a patient? I think that's another thing that's on the audience's mind is, if they want to start a program, remote patient monitoring is a really good way to start treating patients? So are there things that maybe you can give a pearl here or there on billing and coding for those things?
Sure. So remote patient monitoring programs, so there certainly are billing codes for that. Things like 99453, 54, so on. But they're tied to very specific metrics. So for the remote patient monitoring programs, you have to have a Bluetooth capable device. Like it can't be just someone checking their blood pressures and writing them down. You can't necessarily build those codes. There's also a certain number of times, I think it's like 16, they have to check at least 16 times over the course of the month and have those transmitted via Bluetooth. So it can be a little bit tricky, but certainly is helpful way to, one, assess home blood pressures, and two, also get some billing back for doing that great patient care. There are some billing codes that you can use for, the patients who are writing down their blood pressures and bringing them into the office. I think if they've checked at least 12 or 13 blood pressures over the course of a month, you can use billing codes 99473 and 474, I believe, for checking blood pressures in the office for that. I probably underutilized that, but it is available.
I love how you have memorized that code. That's great. Thank you.
Sure.
Yeah, Dr. Bloch, I'm going to let you close us with this last slide, and then there's one more poll if we have some stragglers hanging on, and then we'll close it out.
I think we've covered most of this conclusion here on this slide. I think we've talked quite a bit about use of renal denervation as a potential third pillar of care, in addition to lifestyle modification and medications. We talked about the efficacy. It's ultrasound-based renal denervation, safety and efficacy endpoints, and 3 rigorous randomized controlled clinical trials with an office reduction of about 10.4 millimeters systolic in pooled data, which should, if we agree with the observational studies, translate to about a 20% reduction in cardiovascular events if sustained. We do have some durability data, and we have very important safety data on these patients for multiple years. And I think we talked a lot about putting together a hypertension, a system of care for hypertension that really outlines an approach to how you begin to consider a patient for renal denervation and the importance of patient preference in that final decision making.
Great, thank you. So here is the final poll question for anyone who's left. After hearing all this amazing information from these 2 very experienced hypertension specialists here, would you consider ultrasound renal denervation as a treatment option for your patients who meet the criteria? And you have a couple of options. Yes, I would consider it for my patient who cannot tolerate or cannot take prescribed medications. I would consider it for some of my patients who are truly resistant. I would consider it for either patient A or patient B. And then lastly, I would not consider it for my patients. So I'll just, as people are answering, I'm just going to thank both Dr. Bloch and Dr. Randolph for their expertise and sharing some of their pearls with us this afternoon. And we will have more events like this to come. We will have perspectives from other physicians, interventional cardiologists, and kind of pick their brains on their journey to help manage their patients with hypertension. And I really appreciate both of you for agreeing to join us and share your experience.
Absolutely. Thanks for having me.
Likewise.
Thanks. Yep. And we'll just see what the poll is. Oh, they would 100% said they would consider it for A or B. So great job. I'm sure it was because of what you informed them on today. And I'm going to let everyone have the rest of the afternoon off. So enjoy, and thank you again for joining us.
Thanks.